Hi, this is Dr. Gary Schwartz from Associated Eye Care, and I'm going to give you a short presentation on herpes simplex virus and varicella zoster virus infections of the eye. So the first thing to understand is we'll talk about herpes first, and then we'll talk about shingles later. So herpes can infect any part of the eye and what we call the adnexa, which is the tissue around the eye. It's usually herpes simplex virus 1. And many patients will have a history of recurrences on their lip. So patients who present with what we think might be herpes of the eye, a lot of times we'll ask them, do you get cold sores on your lips? And if they say yes, then that helps us with making that diagnosis. Now, herpes in the eye, it can be an infection with live virus, but patients can also have a straight immune response to viral proteins or altered native proteins on their cells. So one of our jobs as eye doctors is to figure out, is this patient having an infection due to live virus, or are they having an immunologic response? And the treatment's obviously going to be different. The majority of patients with herpetic disease of the eyes will have recurrent disease, and it tends to recur in similar ways. So if it tends to be one eye, right versus left, or it tends to be the same part of the eye. Some patients will get recurrent infection of the cornea, some patients will get recurrent iritis, some patients will get recurrent blepharitis, but it tends to be the same eye and the same part of the eye when it recurs. And HSV is a serious infection. I mean, it's the leading cause of infectious corneal blindness in industrialized countries. So it is a significant public health issue. Okay, so the hallmark of HSV infection of the front of the eye is erosions, these vesicular erosions with loss of epithelium. So if the problem is a blepharitis, we get these erosions here. So these are actual breaks in the surface epithelium of the skin. So if we have someone with a red eye who has this on their lids, this is herpes blepharitis with a concomitant conjunctivitis. The hallmark corneal features, and they're green because this eye is stained with fluorescein, are these erosions in the cornea that have this dendritic branching shape. These are called dendritic ulcers or dendrites, and this is classic for herpes. And again, the hallmark is it's an interesting branching shape, but it's a breakdown in the epithelium. There's no epithelium in the areas that are stained green. And likewise, you can get a herpes simplex virus conjunctivitis where the lid's fine and the cornea is fine, but they just happen to get their lesion on the conjunctiva. And conjunctiva stains with fluorescein the same way cornea does. So 3 parts of the eye and adnexa, but the fundamental lesion is the same. It's a vesicular eruption, breakdown of the epithelium. If you go farther back in the eye, it tends to present a little bit differently. You can get a recurrent iritis. So here we're looking at an area where this isn't an active infection or inflammation, but this part of the iris is atrophic now from recurrent herpetic disease of the iris. And here we have a retinal vasculitis. This looks a lot like cytomegalovirus that we used to see a lot with AIDS patients with significant immunodeficiency from their AIDS. And cytomegalovirus is a similar type of virus to herpes. So here we have a herpetic vasculitis of the retina. But this just demonstrates how herpes, even though it's known for its corneal disease, it can actually affect any part of the eye. So now let's talk about the treatment of herpes simplex virus disease in the eye. So as eye doctors, we have to manage the infectious component with the inflammatory component of the disease. And we can't just treat the inflammation part without treating the live virus part. Otherwise, we'll hurt the body's ability to kill the virus, and it will allow it to spread. Because of the recurrent nature of HSV disease in the eye as well as elsewhere in the body, as I'm sure you're aware, a lot of patients do learn to self-treat, and it's not uncommon for us to allow patients to have a standing prescription order at a pharmacy. So if they feel their symptoms are coming on, they know to start taking the medicine. And some of them will just take the medicine and self-treat for the whole course. Others will take the medicine for a day or two and then come in and see us so we can see how they're doing. But by taking the medicine for a day or two, it will help blunt the severity of the disease. And just like other parts of the body, taking prophylactic antivirals can be very helpful at preventing recurrences. So here's an example of why it's not good to just put these patients on steroids without treating with antiviral. So here's a classic dendritic ulcer. We saw this picture in the last slide. And if this patient were to go on steroid eye drops without going on antiviral medicine at the same time, it could grow into this. And this is because the body cannot kill the virus effectively because of the antiviral medication. So this is one of the reasons why, as I've said in a different lecture, if a patient is going to go on steroid eye drops, it's good for them to be managed by an eye doctor. If a patient is sick enough to need steroids, they're probably sick enough to be managed by an eye doctor. So let's switch from herpes simplex to varicella zoster. And the message here is V1 is just another dermatome, right? So here we have this list of all the dermatomes. I'm sure you're very familiar with this map. And V1 is just one of them, right? So here's a blow-up of the eye. V1 goes to the tip of the nose, and the branch that goes to the tip of the nose and inside the mucosa is the nasociliary branch of V1, which also goes to the eye. So the idea is if you have a problem at the tip of the nose, that's called Hutchinson's sign, you're more likely to have problems with the eye. So here's a picture of somebody with a V1 distribution of shingles. We don't know if it involves the eye or not, but this classic one side of the face, perfectly delineated, and it exactly lines up with this V1 distribution here. So this is somebody who has a V1 distribution of shingles. Do they have ocular shingles? I don't know, their eyes closed, but they at least have a V1 distribution shingles. So that raises kind of an interesting delineation. So varicella zoster and the V1 distribution can be around the eye, which means it can just be the lids and the face where the eye is not involved. It can be on the eye, which means the lids and the face on that side, but also the surface of the eye, cornea, conjunctiva, or it can be in the eye, which means structures inside the eye are involved, like the iris and the ciliary body, possibly the retina. So these are the three different things that we have to figure out which of these three categories does my patient fit into. And the easiest delineation is the eye red? If they have these facial features, but the eye itself is white, then we're probably safe here. It's just around the eye, but it's not involving the eye. If the eye is red, then it's either on the eye itself or inside of the eye, and then it's our job to manage them appropriately. So how do we manage them? So typically, if you have a patient with shingles and the V1 distribution in your chair, we'd like to see them within a day or so. And if the eye is red, we'd rather see them quicker. If the eye is white, you probably have a day or so before you emergently need to do anything. If the eye is white, we typically don't do anything more than you've probably already done in your office, which is put them on oral antivirals. And we either say, come see us if your eye turns red, or come see us in a few days, depending on how they look to us and different preference of different eye doctors. If the eye is red, now they're in the on the eye or in the eye category, and we will add topical corticosteroids to the oral antivirals that the patients come in on. And then we'll see them more often. So regardless of how they look to us, we keep them on the oral antivirals that you've started them on, and then the question is, do we add steroids or not? So takeaways. Herpes simplex virus and varicella zoster virus can affect any part of the eye from front to back. They're serious infections. These can cause blindness. We typically have to balance antiviral and anti-inflammatory treatments. For shingles, the antiviral has to be oral. For herpes simplex, there's a little bit of variety, and different doctors will have different preferences, which means you might send a patient to one doctor who puts them on like topical ganciclovir gel, and you might send another patient who looks exactly the same, and a different doctor puts them on oral Valtrex. And your question is, what was different about the first patient than the second that one patient went on topical and one patient went on oral? And the answer might be the patients were the same, but they just went to a different eye doctor. There is a little bit of leniency in how these get treated. HSV tends to be recurrent, and patients will learn their symptoms, and a lot of them will have standing orders for medications. Their symptoms tend to be the same. If they tend to get a left eye HSV blepharitis, that tends to be how they present time after time. If they tend to get a right eye keratitis, that tends to be how they present time after time. And prophylactic doses of antivirals for recurrent HSV disease can be very helpful. For shingles, I think vaccinations is really going to be a game changer, especially this generation of younger people. When they get to be our age, we're going to see a lot less shingles because we saw a lot less chickenpox. So thank you for your attention. Again, this is Gary Schwartz from Associated Eye Care. If you have any questions, my email address is below. And also, if you have any ideas for any further talks, please feel free to drop me a line. Thanks.